So welcome everybody to the course today. I'm super excited to be sharing about the oral gut axis, and we're going to be exploring the oral microbiome and digestive health today. So I'm super excited to be kind of tying in the oral systemic connection tonight because it's definitely a passion of mine. I do have a couple course disclosures on this. I work for Bristle. If you are doing salivary diagnostic testing with Bristle, I do all of the clinical aspects of training. So if you're thinking about implementing it into office, I do the initial training and then I'm your support person for that clinical aspect for adding it into office, how it's going to work in your workflow, how to read the test. And I help with result reviews to understand the test and how to implement different modalities into your office for treating the oral microbiome. So the research that's in the presentation today is my research, and it's my presentation. There's probably some information in there, even Brian will probably have some fun with. So today we are going to talk about the oral gut axis, exploring the oral microbiome and digestive health. So I'm hoping to give you a deeper understanding that the oral microbiome doesn't just stay in the mouth, and it can have some profound impacts on gut dysbiosis. I'm hoping to help share how to recognize dysbiosis in the oral microbiome, but then also see some of the signs in the mouth that might be pointing you to not just an oral issue, but a gut problem as well. So the course objectives for today are to identify oral and systemic patterns that signal oral gut dysbiosis issues, recognize certain bacteria in the salivary diagnostic test that can have inflammation contributing to both gut dysbiotors like IBS. SIBO will be talking about some other disorders as well, and hopefully show you that we can leverage oral microbiome testing to identify potential risk factors for digestive disorders, not just oral disorders. And I do have some strategies on how to treat that at the end of our presentation today. So I'm super excited to begin with our dive on this slide. And this kind of gives you one inclining on the Bristle test on how we can share that we have a gut impact score on our test that we have for you for the oral microbiome. And we're not looking at gut dysbiosis like Tiny Health would be, but we're looking at the oral bacteria that have the ability to translocate and be implemented in IBS, Crohn's, colorectal cancer issues through swallowing or being introduced into the bloodstream through a translocation. Now, there's tons of research on how the oral bacteria like PGAA, Treponema can be swallowed or introduced into the bloodstream, and they have a downfall on neurologic issues, heart disease, endocrine disorders, gastrointestinal disease, cancers, immune system. The list goes on. We will be focusing on the gut oral axis today. So let's begin by meeting the key bacterial species that kind of play a role in this story. So the bacteria that bridge oral and systemic disease are typically PG, Treponema, AA, Tella intermedia, Fusobacterium, Campylobacter, your red complex and orange complex bacteria. When they're swallowed, they can be a real big problem for balance, not just with inflammation in the mouth, but it leads to inflammation downstream. So with oral microbiome imbalances, and when we have gingival inflammation and periodontal disease, or I like to invite maybe just dysbiosis in the oral environment because not everybody is prone to periodontal disease. When we have high pathogen loads, and then we add stress to the immune system and those dysbiosis, and when those pathogens gain the ability to translocate from the mouth, they can then cause an inflammatory seeding within the body. So let's just kind of look at how that sort of plays out a little bit. So in non-alcoholic fatty liver disease, for example, the problem isn't just fat accumulation in the liver. It's actually an immune system activation process. And the translocation of the bacteria and the endotoxins can keep the immune system in overdrive. And when that happens, cells like T cells and natural killer cells release, and then that then cascades into tumor necrosis factor alpha, interleukin 6, and reactive oxygen species. So that then will cause inflammation in the liver and prevent healing and promotes scarring in the liver. I actually work with Karen Plymell, and she does liver ultrasounds regularly on her patients because she's recognizing that lipopolysaccharides can excite this inflammatory cascade in the liver, and we need to find where that bacterial overgrowth is, reduce that so that we can then bring down the inflammation in the liver to reduce non-alcoholic fatty liver disease. So it's super fascinating that we can look at that. So when the fatty liver disease progresses and adaptive immunity starts to step in, then we get B cells and T cells, and those release more interleukins, and the cycle continues. And it's not just the liver that happens. We also have that in the gut as well. So especially people with IBS, it's all about cytokines and interleukins. So I always kind of teach with periodontal disease, we can have the bacteria present, but we also need to look at the cascade of inflammatory issues that we have in the body that's contributing to bone loss in the mouth. So it's a two-way direction when it comes to oral and systemic inflammation. So it's super fun. This dysbiosis is both gut and mouth, and it's all about those cytokine inflammatory cascades. So we need to start targeting the oral environment and start looking at the oral environment, especially if we're practitioners like we have in the audience today who are not in dentistry, but recognizing that the oral microbiome can actually impact and increase risk factors for IBS, Crohn's, and even fatty liver disease. So it's really important to understand that these cytokines are not just communicating with the oral environment, but the entire system itself. So we've established that the mouth is a messenger, and it can even be a carrier for inflammation. So when we start looking at that relationship, patients with IBS also usually have periodontal disease, and that's where we start to show that oral gut access, and it's truly connected. It's a two-way street. Like I said, I'm constantly teaching the dental field like we have a triangle. So if we're not looking at the airway, we're not looking at the guts, we're not really looking at all of the cascades of inflammation that might be taking place. And I really encourage a lot of practitioners to also look at the mouth and see if we have oral pathogens that are translocating and also implementing inflammation that could be that downstream impact for IBS and Crohn's issues. So, we have a gut liver loop also that can be a problem as well. So these bacteria don't stay in one spot, and they can have a cascading effect on the brain, the liver, and in the gut when they translocate. Ooh. Back to this one. Sorry, I got one ahead here. So I just want to kind of introduce this really cool study. And this one's a little bit different. A lot of times we'll talk about PG, TD, and all of the red complex species. I love diving into other research and what else is out there that's going to cause some inflammatory issues. So I found this really cool study on IBD, and it's linked to overgrowth of bacteria. And if we kind of look at the gut story again and zoom into certain bacteria, we can compare healthy individuals against those with inflammatory gut conditions and start recognizing bacterial shifts and patterns. And in this study, it was really interesting because I always get interested in other bacteria, not just the red complex species that all of us are worried about. But in this study with IBD, you can see an increase in Firmicutes, Bacteroides, and Actino species. These bacteria tend to thrive in inflammation. So if we have inflammation in the mouth, they can be risen. And if they have inflammation in the gut, they can thrive as well. So while these rise, then we have beneficial bacteria that tend to help with stabilizing, then decline in a circumstance. So as that balance of the ecosystem tips, these peacekeepers, the beneficial bacteria, then kind of step back, and those pro-inflammatory players can kind of move into the space. So in this study, Vionella and Prevotella are dominant, and they're joined oftentimes with Atopopum and Rothia, which also thrive in a more acidic environment and an anaerobic environment. So once again, we start to get a biofilm going on with these clumps of bacteria that are pro-inflammatory, and they like to thrive with each other. So anaerobic, acidic-loving bacteria translocate really well because sometimes we don't have enough acid in the stomach, especially if we have patients with, acid reflux and they're taking proton pump inhibitors, and now we're not going to mitigate those because the acid level is not high enough. So in the healthy controls, they were rich in bacteria in Neisseria, Streptococcus, Haemophilus, Porphyromonas, Fusobacterium. Yes, Porphyromonas and Fusobacterium can actually be helpful in some circumstances. So it's oftentimes when we start thinking about Porphyromonas or Fusobacterium, we instantly think pathology, but those can actually help maintain balance and microbial diversity. So not all Fusobacterium or Porphyromonas species are bad. These bacteria play a quiet role in the background in supporting mucosal health and preventing overgrowth of some of these aggressive neighbors that we might have, like Vionella and Prevotella. I spend a lot of time in the backside, the raw results section, and start looking at the Prevotella and the Vionella, especially when I'm thinking maybe the test isn't really giving me everything I might be looking at, especially for some of the functional medicine doctors who might not know about all the red complex species that can have that cascade like the original slide that I showed, but there are some other ones in there that we might want to look in the back side of the test and just check in on a little bit. So saliva is awesome. Here's another one that I do check in the back side of the results. This is another one that actually can get pretty opportunistic. I brought in a little pie chart here, and in this pie chart, Prevotella melanogenica is at over 20%. I actually see this quite a bit. This one is a facultative bacteria, and those facultative ones are a lot more adaptive and tend to run sometimes on higher relative abundance. So I do look for this one in the raw results section when I have patients who have inflammation. Fun facts about this Prevotella species: it's a chromogenic bacteria. So it produces pigment and can contribute to black line staining on teeth. So hygienists, if you have black line staining, look in the back side of the results and look for this species. It also does have some inflammatory cascades in the mouth, but it can be tied to ulcerative colitis as well. It's one of the ones that I love kind of looking at in the backside. So it can contribute to oral and gut inflammation. So this Prevotella species is strongly linked to gut health issues, particularly ulcerative colitis. And this research article that I have cited here shows in levels that are significantly higher in patients, which in this pie chart, it's at 20% relative abundance. So it would be probably on the higher side for this patient. And I start thinking, not only maybe do we have gum inflammation from this bacteria, but perhaps if it's getting swallowed, could it be also triggering some IBS or Crohn's or colorectal issues with the patient as well? So important to understand too that Prevotella isn't always automatically a bad bacteria. In small amounts, it can actually help break down our carbohydrates. It also helps to support microbial diversity. We want diversity in the oral environment and in the gut ecosystem. But when it's in larger numbers and we have a big eco shift, it can turn from a good guy to a more pro-inflammatory bacteria and be implemented in some pro-inflammatory issues with IBS and Crohn's issues. Another grouping of bacteria that go beyond just PG and TD and all of the ones that everybody kind of knows about in oral diseases is the enterococci groups. I love talking about the enterococci groups. It's kind of my jam. But let's just kind of focus on these ones. They can be pretty troublesome in the oral environment and in the gut. These are, like I said, some of my favorites to talk about. I have a really cool course on my website on these species. But what's in the enterococci groups? It's going to be Klebsiella, Enterobacter, E. coli, Citrobacter, Serratia, and these microbes get in real overdrive. They get into, very high relative abundances. And when these microbes are in high abundances, it can be a condition to cause both oral and gut inflammation. And I found a lot of research on when this balance is lost, the inflammation rises and they become opportunistic in nature, which they can become very opportunistic. I'll show you this in the next slide. When they multiply rapidly and compete, oftentimes I'll have very low beneficials and they start feeding off the oxygen and the nutrients on tissue inflammation and really thrive in inflammatory issues. And they're highly tied to mucosal inflammation, barrier dysfunction. They enhance pathogenicity of other bacteria. They increase complications with obesity related diseases, cause low systemic infection issues, inflammation, and they're very dysregulatory to the metabolic system. So recognizing when we have enterococci is really important. And I probably see at least one or two cases come across my bristle testing, which is why I become super passionate, because it's outside the box of some of what some tests are looking at. So I'm going to dive a little bit into Klebsiella, which is part of that group. And this little pie chart, I love breaking things out and showing you what relative abundance looks like. The Bristle test is a little bit different. We don't give like quantitative numbers. We're working off relative abundance, and relative abundance is really important. It's like a pie chart or a garden of where everything is kind of living in harmony. And with large relative abundance, you can see this Klebsiella pneumoniae specifically is at 46.7% relative abundance. So it's taking up almost 50% of the oral microbiome. And what happens is all the other stuff kind of gets squeezed over, and usually the beneficial bacteria just get completely depleted when we see a test with a relative abundance of this. And it's super interesting. I like to just share, like, oftentimes when we think of opportunistic bacteria, Candida comes to mind for a lot of people. And in the Bristle test, I think the relative abundance at 100th percentile, I've seen it at 0.40%. So true opportunism is really with these enterococci groups that get in a lot of dysbiosis. And at the below this pie chart, I brought in a wheat zoomer test from a functional medicine doctor that shows you that the enterococcis are also tested in the gut, and their potential is to have intestinal permeability issues. So we really need to pay attention to what's in the mouth and how that's translocating. Klebsiella triggers interleukin 1 beta. It releases from the macrophages. And it's interesting because unlike the gut strains, it enhances GI inflammation. We'll get to that in just a moment on how it does that. But SIBO contributes to increased interleukin 8, mucosal inflammation, and that causes bile duct, complications leading to diarrhea and more cytokine storms. So it's important to make sure that we're recognizing who's playing in the sandbox and treating those bacteria so that they don't translocate and cause some of these cascades, because it's really all about the interleukins. So interleukin 1, interleukin 6, tumor necrosis factor alpha, all those inflammatory interleukins that we see in periodontal disease. So I always invite dentists to think about leaky gut, leaky gums, right? So if we have interleukins and cytokines swimming out in left field because we have a leaky gut problem, it's going to feed that autoimmune component of periodontal disease, even with low typical perio pathogens in the mouth. So super fun. And then Klebsiella is a little bit special, kind of moving a little bit deeper into the story. It also has a process called gut homing. So when the mouth becomes inflamed with chronic periodontitis or bacterial imbalances, like I just showed that Klebsiella almost at 50% relative abundance, it can trigger an immune system response and send out specialized T helper cells. And those specialized T helper cells are called Th17 cells. And those are put out to recognize, they have a memory and control the damage. Well, these cells too can then translocate. And when they translocate, they're trained to recognize those species. So if we have a Klebsiella pop up in the gut, it's going to excite that inflammatory issue in the gut and contribute to gut dysbiosis and leaky gut issues. And then that circles back into the mouth. Super fun. It's not just Klebsiella that actually does that. PG or Porphyromonas gingivalis also excites Th17 cells. We know those also get swallowed and they can have this same gut homing effect. And it drives inflammation both in the gut and in the mouth. And it's then more driven by the immune system and the inflammatory response and the bacteria being recognized through memory from the cells that are present through the immune system response. So it's the stage is set with the bacteria, and then the immune system carries the story and the inflammation forward. Super fun. Okay, so have I convinced you that we should be testing yet? So I'm going to just break down a little bit about the Bristle test if you're not Bristle testing yet. Bristle is unique in the aspect that we use shotgun metagenomics in our test. So that means we have a full scope of understanding of the complete oral microbiome. So we're not just looking at targeted species like the red complex and the orange complex, and maybe a few bacteria that cause decay issues. But we look at beneficial bacteria. We have a gum inflammation score, a tooth decay score, a halitosis score, a gut impact score, and a nitric oxide score. And we also look at diversity, and that diversity is where we start looking at if we have very low diversity, we probably have one of those enterKCIs taking over. It has a super detailed results. We have customized care plans, so it makes it easy for communication with patients. And you can bring your own products and customize your own treatment plans and your home care plans for the office and your patient at home. So super great. And it's going to give you some of these key insights. We'll kind of break down some of the information that you'll get from the Bristle test here. So I'm focusing mostly on that gut impact because that's the topic of today. We break it down for the additional health and wellness insights. The gut impact score is not looking at bacteria in the gut. We're looking at bacteria in the mouth that have the capability of translocating and that are tied by research in causing or correlating to IBS, Crohn's, colorectal cancer, SIBO issues. So Klebsiella pneumoniae, AA, Campylobacter, Fusobacterium, PG are all in this scoring. So if we have a high gut impact score, I try to teach practitioners start thinking about how the gut might be impacted by the oral environment, but how the oral environment also might be impacted by the gut if we do have some IBS and Crohn's issues. So it's really cool in the test too. We give you some really cool attributes so then you can start thinking about how you want to approach the bacteria as well. So gram negative have double cell walls. The shape, I'm a nerd. I used to use a phase contrast microscope. So I start teaching people about biofilms versus mobile bacteria, and the test can kind of give a little bit of a call out there. Facultative or anaerobic. Facultative ones, they're a little bit more challenging. They're adaptive. They can live with or without oxygen. Anaerobic bacteria, we can use chlorine dioxide or ozone, oxygen to help bring in and help reduce. And then the last thing that we kind of add in the Bristle test for the attributes is letting you know what oral probiotics act as a bacteriocin towards that species. So lots of information just packed in that one little bar. It's really, really profound at what we can actually help you understand about the pathology that's present there. And I want to remind you that the mouth reflects the gut long before the gut is actually speaking. So when we are doing our oral cancer screenings in the mouth, I want you to start thinking about what the tissues are actually telling you, not just red rolled, periodontal disease, but looking at oral sores and things like that. We're going to get into this shortly, but our oral cancer screenings are so incredibly important on what we're doing. And I want you to start thinking about oral ulcers, cracked lips, and things like that as possibly a sign of a deeper issue going on with our patients. So, according to this research article, we can start connecting some of the things that we're seeing in the mouth with what's going on further downstream. So, oral manifestations of Crohn's disease includes angular cheilitis, mucogingivitis, cobblestoning, mucosal swelling, and there's just so much other, if we have gum inflammation in general, start thinking that maybe there could be some pro-inflammatory. One, because we probably have a bacterial overload with the inflammation, but we can start looking at other factors. This picture kind of shows not just the stomatitis and the aphthous ulcers in the mouth, but you can start to see some changes in the eyes, the kidneys start to have some issues. We can have some skin issues as well when we have Crohn's issues with our patients. And, we can start seeing that. So things to look for clinically as a clinical clinician, and we're starting to talk about oral manifestations of Crohn's. When you start seeing some of these oral sores, what we say.
Just me.
Okay.
Sorry about that, Heather.
That's all right. So with oral sores, don't just think about like a trauma situation or I bit my cheek, but if you have someone who is continuously having sores in the mouth, maybe start thinking about doing a salivary diagnostic test and really investigating whether that person has any GI issues. Oftentimes, these will actually show up before the GI problems actually exist. The prevalence of oral involvement, it varies pretty drastically. Anywhere from 0.5% of patients to almost 40% will show signs of these angular cheilitis, so cracking of the lips, swelling lips, oral sores. Cobblestoning is like bumps in the back of the throat. And cobblestoning can be a little bit on the cheeks, but it's usually looking beyond the uvula and seeing these bumps happening in the back. That's really telling you something else is happening. There might be some ulcers downstream that we need to start thinking about. So Crohn's disease can show signs in the mouth through oral sores. And if we start thinking about how, if we have a leaky gut issue, we also probably have some vitamin deficiency issues. So we're not able to uptake our vitamins. And once again, we're seeing some of those sores. Glossitis, inflamed tongue, cheilitis, swelling mouth syndrome or burning mouth syndrome, mucosal atrophy, gingival bleeding, delayed wound healing, risk of periodontitis, dry mouth issues, oral infections, compromised mucosal integrity, so perio. So vitamin deficiencies too will show up very similar in nature. So it's all about the gut when it comes to what's going on. If we have these vitamin deficiencies, we probably have a leaky gut problem, and we can see that through oral signs and inflammation in the mouth. So we're going to want to fix the gut so that we can fix the oral signs and the disease progression in the mouth as well. So start thinking about collaborating with practitioners as clinical providers in dentistry. And then I really encourage a collaborative relationship between doctors to start looking at what's going on in the mouth and start thinking about dental treatment for pro-inflammatory issues in the body. And I pulled this information. This is one of my slides that kind of interpret for perio patients, because sometimes we'll have perio patients that have a low gum inflammation score, and we are still presenting with periodontal disease. And this is where I start inviting our clinical practitioners in the dentistry world to start looking at the gut impact score and the nitric oxide score. The nitric oxide score, too, we look at the bacteria capable of reducing dietary nitrate, but the gut plays a role in that as well. So if we can take the bacteria and we have a good dietary nitrate uptake, but we don't have nitrate in the oral environment, we're relying on the gut to transition nitrite into nitric oxide. So nitrate into nitrite, the gut then finishes that transition. So if you're testing for nitric oxide in the mouth through strip testing and you don't have it and you have a good capability, maybe there's a gut aspect to that breakdown system as well. So really start investigating when you have that gut impact score. Is the gut a problem? Do we have a pro-inflammatory issue exciting the cytokines that's feeding bone loss in the mouth? Because periodontal disease is all about those same interleukins, tumor necrosis factor alpha, and cytokines. So when we're doing that, we can start thinking about our treatment planning process. And I would invite that a lot of the bacteria in that gut impact score are still in need of treatment, and many of them are biofilm. So we still want to treat with scaling and root planing and other modalities to bring those bacteria down in our therapies, but also start investigating into the root cause. Look at insulin resistance, look at diabetes control, look at gut issues, and start thinking about working on the nutrition, dietary aspects, and getting the gut sound, getting the bacteria in the mouth lower to get the gut sound so that we can promote healing for our patients. Some adjunctive considerations that you could consider for that. I like phase contrast microscopy. This is a slide that I pulled from another deck. Phase contrast microscopy is kind of looking at the live bacteria, and you can kind of start to see imbalances. I think they're a really great start. You can start to see red blood cells and white blood cells and an inflammatory cytokine response there with that. And then definitely, I think testing is the only diagnostic tool that we really need to start doing. It's way more diagnostic, in my opinion, than a probe. We need to know what's present and what we're treating. And then what we're treating, we need to start thinking about biofilm disruption in that process. So ultrasonic instrumentation should be a standard of care. If you're not picking up your ultrasonic with every patient, you should be. Air polishing is a really fantastic way to work on the biofilm, and it's using different powders, like erythritol is the one for EMS, but we also have glycine powders that are on the market too. There's more and more coming out on the market to help us, and those are great and they're really minimally invasive at really working on biofilm. And most of the practices, you're going to disclose the patient and then use the air polishing, and that's usually the first step in the process of biofilm control when it comes to air polishing. So you're not scaling first, you're not using your Cavitron first, you're actually air polishing and removing the biofilm first, because all of these species, Enterococci groups, Porphyromonas, Fusobacterium, they're all biofilms. They're not mobile bacteria. Treponema denticola is a spirochete. It's a mobile bacteria. I always invite people to incorporate lasers when possible. And then there's some really great processes called desiccation therapy using a sulfonated gel. And what desiccation therapy does, it actually dries out the biofilm and the tissues around the teeth. So if we have AA and PG present in a salivary diagnostic test, PG actually embeds into the tissue. So I invite using lasers, desiccation therapy when we have those bacteria that we know don't just sit in the sulcus, or in the biofilm, they can actually embed into the tissues. We need to make sure that we're getting into the tissues to capture those species. So lasers and desiccation are really great tools for us to start using when it comes to those species when we find them in tests. Ozone therapies too can also penetrate the tissue. Ozone is awesome because not only does it reduce pathology, it's adding oxygen in, it's O3, but it also is a really powerful anti-inflammatory and it stimulates healing properties. So it's a really nice biologic way to incorporate a therapy, reduce anaerobic bacteria because we're using O3 and helping to promote healing, which is really awesome. And once we start knowing what's there, we can start doing a little bit more research and finding what might be better. That's what I love learning about. I read a ton of different research articles. I tend to be more holistic. So I love looking at, okay, I have X species. What can I put in play to actually treat that? So when it comes to that Klebsiella pneumoniae, I have found research articles that cinnamon, peppermint, thyme, wormwood, or artemisinin, which is one of my favorite ingredients to use, are beneficial against Klebsiella species. Tea tree, thyme. In some cases, turmeric can help with the biofilm formation and mucus production of Klebsiella pneumoniae. So I tend to choose products that have cinnamon, peppermint, thyme. I use a wormwood product on a regular basis when I get these enterococci groups of species. With Serratia, we have a really cool case study on Serratia, and we discovered that xylitol can inhibit the biofilm formation and reduce. That's another pigment producing bacteria. It's pink and it produces a pink pigment in your bathroom and it blocks that protease activity. Xylitol also stops the swimming and swarming mobility of Serratia. That's a mobile bacteria. And it makes it more susceptible to hydrogen peroxide processes. So we could bring hydrogen peroxide in, or the probiotics like Lactobacillus rudii or Lactobacillus plantarum, they use hydrogen peroxide processes as a bacteriocin towards those species. So we're helping them be more susceptible to the probiotics we might be putting in play. Xylitol also downregulates the virulence factor of Serratia. So when we know what we're dealing with, we can be a lot more scientific in what we might be adding for home care into what we're doing. And that might include even being a little bit more targeted with probiotics. So once again, kind of pulling some information from the Bristle test. In the detailed results, we show you what they have for research on what probiotics can act as a bacteriocin towards the species that we might be targeting. So this Enterobacter chlorei is sensitive to Lactobacillus rudii. So we want to make sure that we're adding Lactobacillus rudii into the oral environment to help reduce. And when we have that extreme overgrowth with like Enterobacter Klebsiella, usually we have a really low beneficial bacteria score. So I want to put probiotics in there. And sometimes I choose a really wide variety. Bristle has 6 beneficial strands of probiotics in theirs. So we can add a number of different beneficial species into the oral environment to help start building that beneficial score and taking up space as we're weeding out it, I don't know, 50% of one specific species if it's in overdrive. One research article that I found against some of these enterococci groups is Lactobacillus plantarum, Lactobacillus rhamnus, and there is research on Lactobacillus rudii are helpful to introduce to reduce that specific strand of Klebsiella pneumoniae. So we can really start by implementing more specific care. I do love to kind of go over the importance of looking at the person as a whole. We should be doing short-term antimicrobials, whether that's in a toothpaste or a rinse. When we overuse antimicrobial rinses, it causes a severe impact on the beneficial bacteria and the nitrate-reducing bacteria. And it's not just Listerine or chlorhexidine like some of the studies. I found many of the products, even the ones that are natural with a lot of essential oils like tea tree, oregano, neem are all broad spectrum antimicrobial. So really, we want to think of that as a tiller. So we till for a short bit of time, but we can't ever grow a garden if we're tilling it all the time. Oftentimes it ends up in dysbiosis, and that lends to those enterococci groupings starting to overgrow. So I love using ozone-based products. A lot of the beneficial bacteria are aerobic, so I can use oxygen and it doesn't really impact those bacteria while it does reduce the anaerobes that are present. So, and then think about nitrate supplementation, probiotics. I always say you have to look at pH too. What's happening in the environment that's caused the dysbiosis to begin with? We need to look at saliva flow. We need to make sure that we have a nice moist community that is balancing and pH balanced as well. So if we don't have saliva, we can't keep the environment healthy to start. So if you don't have dry mouth support products, I highly recommend that you start thinking about finding some products that could support dry mouth for your patients. And diet plays an enormous role for our patients. Many of these species like carbohydrates. So lower sugar and processed foods is super important. But fiber is like a prebiotic for many of the good bacteria. So we want to up our fiber intake. Protein can help with saliva flow and it can feed other beneficial bacteria. Nitrate rich foods, beets, arugula, spinach, celery are going to feed those nitrate reducers and increase those, which is going to help us with blood pressure control, tissue integrity, and then maybe even considering some supplementations because we know if we have gut issues, we probably have some vitamin deficiency problems, and then we might be transporting our vitamins properly. And trace minerals, I usually add to water as well. And then start assisting your patients with collaboration. I love that we have multiple types of practitioners here today because we need to start being collaborative. Dentistry needs to put the head back on the body, and we need to start working collaboratively with practitioners. I get the pleasure of doing that on a daily basis with Bristle and educating on the oral environment and how that impacts systemic health. So I love encouraging a more collaborative conversation across dentistry and medicine because the mouth can be majorly problematic. And then in the mouth, we can't correct things if we have hormone imbalances and vitamin deficiencies and gut problems. We're not always trained in nutritional counseling effectively. We need to look at the airway and whether someone has sleep apnea issues and dry mouth problems. So we really need to start working collaboratively to help promote health in that perspective. Hey, I rocked it tonight. I'm on time, actually early. So if you want more information, I am the clinical trainer here at Bristle. And if you sign up with Bristle and you start testing, I will be training your team. And I do result reviews, so I'll walk you through the test results and kind of some of the fun innuendos that I found after working for Bristle for almost 3 years and using the test for about 5. I do have a really cool website. I'm building continuing education and other courses, and I'm super excited to be starting a community called the Saliva Sleuths. So, in that, I will be doing webinars once a month, and I'm doing bi-weekly open microbe nights on Mondays where I'll be inviting other people to share and collaborate and help everybody kind of share what they're learning about the oral microbiome, oral health, systemic health, how that ties in, do case studies and things like that. I also have some fun cases that I'm putting together. So we'll have some case studies and some investigations and some deep dives into dossiers. And it's really on a detective basis. So if you are interested in becoming part of a community and learning the oral systemic connection, please join me soon for the Saliva Sleuths. I think that's going to be up and running in the next 2 weeks or so. Amanda Hale is in here, and she is my partner on Functional Roots podcast, where we talk about biologic hygiene and all things root cause. So, and then of course, I'm super passionate about teaching about what the Bristle test can tell you. So I hope you guys all enjoyed. the presentation today, and I hope you learned a ton.